On with the sessions. That is, next is the bladder outflow obstruction conducted by Professor Srinath Chandrasekara, consultant genitourinary surgeon. And to chair the occasion, I cordially invite our president of the college, Dr. Mrs. Malkanthi Galhena, and the secretary of the college, Dr. Priyantha Halambarachige.
I invite Professor Srinath Chandrasekara to deliver his lecture today on bladder outlet obstruction. It's with great honor and privilege that we introduce Professor Srinath K. Chandrasekara, consultant genitourinary surgeon, lecturer at the Department of Surgery, Faculty of Medical Sciences, University of Sri Jayawardhanapura, Sri Lanka. He obtained his postgraduate training at the PGIM and the King's College Hospital in London. Professor Chandrasekara stands as a trainer in undergraduate and postgraduate urological surgery. He has served as a president of the College of Surgeons and the Sri Lanka Association of Urological Surgeons, and he also held the position as chairperson of the Specialist Training Board of Urological Surgery. Today, Professor Srinath K. Chandrasekara shall grace us with his insights on an important in urology, bladder outflow tract obstruction. It's over to you, Professor Srinath.
Thank you, Dr. Galhena, the President, for the very kind introduction, and it's lovely to share the stage with my good friend Priyantha Halambarachige. He was my batchmate, and we've shared lots of wonderful memories in med school. So I'm going to keep this time on so that I will try my best to stick to time. As you know, bladder outflow obstruction is a very important topic. And at the same time, it's a very long topic. So I'm going to do my best to keep to time. So let me tell you that this is one of the common problems, surgical problems that family physicians, as we call you all, encounter in practice. And it is not just BPH we talk about, there are numerous causes. But I'll just keep going. And so, as you know, there are numerous causes. Today, I'm going to focus on the aging male and the problems, because outflow obstruction can occur in females, different set of problems. It can occur in children, as you know, due to different, it can be neurogenic bladder, or in males, commonly due to posterior urethral valve. So it's too vast. I'm not going to talk about all that. In females, it's commonly, if it's a postmenopausal lady, it's urethral stenosis due to the deficiency of estrogen. And in the younger male, there can be problems due to pelvic masses, fibroids, retroverted uterus. So we can't, and we are not going to address all these issues. We are going to focus today mostly on the aging male and the outflow tract obstruction which occurs as a result. So you know this very basic diagram. So the bladder and its outflow is called the lower urinary tract, and the kidney and its ureter is called the upper tract. So we are going to talk about the lower tract mostly, and in this instance the male. So what are the age-related problems? Age-related benign enlargement is one of the commonest issues, but don't forget that prostate cancer in this age group presents very similarly in its early age. In its early stage. So as a family physician, it is important for you to differentiate, which is not always easy, between benign and malignant disease. Sometimes acute infections, prostatitis, can also present with some degree of prostatic swelling, inflammation, and as a result poor flow, but this is a more acute situation, which is mostly the presentation is that of a UTI. And strictures are the other issue, but once again, this is something that builds up gradually and more frequently than otherwise. You find antecedent reasons such as infections, recent catheterization, or instrumentation. So what are the common urinary symptoms? There is a mixture of symptoms: frequent urination, urination at night, urgency, difficulty in initiating, poor flow, a sense of incomplete evacuation. All these are common. So it's not just the outflow obstruction related poor flow and dribbling. Sometimes even the filling type of symptoms, as we call it, can be the first presentation of an outflow issue. You're all very familiar with this, so I'm going to skim through this. We do not call it prostatism any longer, so don't use that term. We call them lower urinary tract symptoms because these symptoms are related to the lower tract and not prostate specific or disease specific, and the different type of symptoms which occur in the filling phase of the bladder and when the passing urine, which is in the voiding phase of the bladder, are listed here. Again, for purposes of time and clarity, I'm just going to leave it at that rather than itemizing each one of them. So LUTS is the abbreviation, and it's a standard term that we can all use. Now let's get on to presentation. I'm now going to focus on the prostate, and bladder outflow obstruction can present in different ways. LUTS, as I explained to you, is one of the commonest presentations, but sometimes patients present with painful inability to pass urine with a full bladder, and that's called acute retention. Some people have retention of urine in the bladder but are able to pass urine either due to overflow or with some straining, and there's no pain, but there's a large amount of urine left in the bladder, and that's called chronic retention. Sometimes, due to chronic retention, patients also present with further complications of outflow obstruction, such as infections, stones in the bladder due to stagnation, prostatic hematuria, I'm sorry for the spelling issue there, and of course, overflow incontinence, which is called enuresis. So these are all common presentations of outflow obstruction. Another important message, the degree of symptoms, and when it comes to the prostate, the degree of prostate enlargement and the dynamic element of obstruction do not go hand in hand. So it is not always the person who has the greatest degree of symptoms who may be having the most amount of obstruction or any other combination. So it is not a linear relationship between prostate volume, the degree of symptoms, and the degree of obstruction. So if you find that the patient is very symptomatic with a small prostate, remember it's entirely possible. So coming to family practice, what are the reasons for LUTS in men over 50 years? I told you BPH. Sometimes social and dietary habits. People take a lot of water and they go all the time and they think it's due to prostate issues. No, they're consuming a lot of water, sometimes beer, sometimes alcohol, which can precipitate these habits. Prostate cancer, strictures, infections, and as a secondary effect of other illnesses. Udita and Dr. Ratnapal gave a fantastic lecture. Sometimes even this urinary frequency can be a result of early diabetes or the first manifestation of diabetes. Neurological problems, sleep disturbances, which makes them wake up and then ending up in the toilet because they are woken up and they want to empty the bladder. Don't forget these ancillary causes, and it's not always the prostate which plays up, giving rise to these symptoms. So it's important for the family physician to figure out whether these issues are recent onset or long-standing. You'd agree with me that recent onset symptoms are more worrying than long-standing. If a 65-year-old man comes and says, look, for the last 5 years, I've been having a moderate stream, difficult to pass urine, and I wake up once or twice at night, well, you know, yes, it's likely to be BPH, but this has been going on for a while, it's not progressed. Whereas a similar age person saying, look, I've got this symptom which is going on and progressing rapidly, and it's much worse than it was last month, well, you're more worried. Maybe it's rapidly progressing because it's a malignancy, maybe there's a secondary cause, maybe there's something more sinister going on. So recent onset and progressive problems require closer attention than sometimes symptoms in this aging group where it has been going on for a longer period of time. Now, associated fever, hematuria, loss of appetite, back pain, those are alert signs. In family practice, you find a patient coming with outflow symptoms which I described to you with these signs. These are indications for urgent referral. So it's not just BPH or outflow obstruction. You've got something else going on. You've got infection, you've got an inflammatory process, blood in urine is tumor until proven otherwise, loss of appetite, back pain, is it a cancer metastasis? So these red alert signs should not be and must not be ignored and requires urgent referral. Also, in the patient who's got moderate symptoms, inquire about lifestyle, fluid, diet, recent medications, which may all have an implication on the symptoms that they present with. So what do you do if these patients develop these symptoms? If the symptoms are mild and you find no other major reasons, inquire about the lifestyles, and sometimes restricting fluids in the night, giving them appropriate advice about bladder emptying or dietary habits, consumption of alcohol, beer, these things help. See your GP, that's what he says. So GP, your family physician, our family physician, you people are the first port of call. You own your patients. You refer them to us. So you have to look after them. So the first port of call is the family physician, and the basic tests are often done in family practice. And I've listed them out again. I'm not going to read. Urine analysis, a blood count. If you think the patient is over 50, 55, counsel them with regards to the need for a PSA. Although you know it's not a very accurate test, it can go up due to many reasons. Get these things done along with an ultrasound to look for the bladder volume, residual urine, prostate volume, and this many of the family physicians who refer patients to these basic investigations, we are delighted to see them. And we write back and say, dear Dr. So-and-so, thank you for referring. You've done the needful. I would only endorse your diagnosis and then recommend that you carry on the same medicine you give. So that kind of proactive action by the family physician makes the patient referral, when required, very efficient. So I would like you to remember some of these basic tests that are done when patients present with outflow obstruction, and it is awfully useful and saves a lot of time and energy for the patients to come to a specialist when necessary, of course, with these tests. So this is highly recommended but hardly used questionnaire. It is so everywhere in the world, not only in Sri Lanka. Hardly anyone uses this, but at least ask the last domain, the quality of life. So you can access this on the web. You don't have to, look at all these domains. This is a questionnaire looking at the degree of bother. So each of these symptoms are given a score. Therefore, you'll have a minimum and a maximum score. You can quantify, you can evaluate progress with treatment. If you can't do all that, just try to stick to the last quality of life domain and to ask the patient how much it bothers or how much these symptoms bother these patients in the recent past, and that will be a good indicator for you not only to look at the severity but also to assess the response to treatment. I'm just marking time so that I'm not going to overshoot. So when do you refer? If the family physician's tests are inconclusive, if they're abnormal, I think it's good that you refer to a urologist. If the symptoms are not alleviated by initial medicines, which I'm going to talk about, well, that's another indication. Maybe the diagnosis is different, maybe the problem is more severe, maybe we are looking at something. Now, as family physicians, you have a very important role about knowing moderately about everything. And I don't think I'm insulting anyone by saying that. You need to know everything. Whereas we urologists or specialists know a lot about some things. So whose job is more difficult? It's your job that is more difficult. Right? We stick to the kidney, ureter, bladder, and we try to read and learn and learn a lot about a single system. But you have to know a lot about everything. So I don't think specialists, or certainly myself, or my specialty requests you or expects you to know everything. So if the basic tests are abnormal, if you think this is not right, if the patient is not responding, if the patient requests, make a referral, and that is mutually beneficial. Same goes with the DRE. DRE is a mandatory part of a lower urinary tract assessment when the patient comes with LUTS or bladder outflow obstruction, but it is always not necessary for the GP to do that. But it requires a bit of training. Even our senior registrars, when they do a PR, we go and do it again to make sure that their judgment matches with ours. Because it requires, like many things, like looking at the fundus. I can't look at the fundus. I can't even figure what to see there. But you can. So if you think a DR is necessary, if you think further assessment is necessary, please refer on. So these are the objectives of prostate assessment by a specialist. We want to confirm that this is BPH when it is often so, and we also want to exclude prostate cancer. So it is best done by a urologist in most cases, not all cases. Exclude other causes. So this is necessary when the picture is not very clear. Assess severity and, of course, determine optimal treatment. Now, this can be done by a GP in the initial instance, and if it responds well, that's fine for you. But if you are not happy, then you need to refer the patient on and make sure that there is a proper assessment and a line of action or a plan, because Sri Lanka, or in this part of the world as well, people are now becoming more litigious, so the last thing we want to do, you and I both, is to miss a prostate cancer or some other sinister cause, or for that matter, a complication of BPH. So essentials of prostate assessment, as I told you, is a DRE. It's not a very looked forward to thing by patients, but when done carefully with lots of lubrication, it's not that much unpleasant. It shouldn't be painful at all. And sometimes we find patients with rectal stenosis or the painful anal conditions, and we need to be very, very, very gentle. And sometimes we defer it because there can be sometimes a lot of pain. Unfortunately, we haven't got this fantastic gadget invented or validated yet, so it's just a cartoon as a joke, but essentials of prostate assessment includes a DRE by a trained hand. So, you know these tests, urine flowmetry quantifies the degree of flow, and I've just given 2 slides here. One shows a nice tall peak like that, and that's a typically unobstructed flow, and the maximum flow, or the peak of that, should be more than 15. And the other shows a kind of a more blunted flow with a prolonged voiding period, typical of outflow obstruction. It's a simple test, not expensive, unfortunately not available in most government hospitals, but available in Sri Lanka in all parts of the country. And all what we do is to just pee into a toilet which is fitted with a flow meter, and that gives us a quantification. So it's good to train your eye. So what I used to do when I trained my eye to CT was to read the report and then find those findings in the images. So after a year or 2, I could then figure out what is in the report and then find that there. Now I do the reverse. I read the slide or I read the films and then find out whether the report shows that. And often I find that there are things that I do not agree with, and which I need to consult the radiologist with. So when the patient comes back to you, and we always refer back, I always write back to my referring GPs. I always do that. And when I do, you'd find what the urologist's conclusion is, and then you can train your eye as to what is obstructed and what is not, and that's a very good practice. And this is something a family physician, especially at specialist level, should be fairly conversant with. Ultrasound is the most conversant and most versatile assessment for bladder outflow obstruction. It gives us the pre and post void residual urine volume, and as the post void volume increases, the chances of outflow obstruction becomes greater, and other things like bladder wall thickness and the degree of prostatic protrusion into the bladder. Now here you can see the prostate is jutting into the bladder. These conditions are more difficult to treat medically and often ends up having some sort of surgery sooner than later. So a few words about PSA. It's one of those wonderful things which has saved many patients, but it also is a very variable test. Remember that PSA goes up due to numerous reasons, and the commonest reason why PSA goes up in our patients is due to inflammation and infection. I've done an audit which is not published yet to show that more than 50% of the patients who come with above normal PSA settle down with some antibiotics because they have some subclinical or clinical infection going on. So don't make a judgment with a PSA with one report. So if the PSA is high, you need to kind of alert the patient that it requires assessment, but don't jump into a diagnosis and tell the patient that he's likely to have prostate cancer. It's often a prostatitis. So you treat them with antibiotics, repeat the PSA, and this is a short half-life, it comes down. So I've listed some of the common reasons why PSA goes up. Of course, large prostates, large BPHs, as well as prostate cancer are all important causes of elevated PSA. So it's a non-specific test for cancer, but a specific test for the prostate. So various problems in the prostate can cause elevation in the PSA. I hope my message is very clear, because PSA is done commonly and is done commonly by family physicians, and we must know its uses as well as certain inaccuracies that we need to judge. So moving on, as the outflow obstruction due to whatever the reason, and often BPH progresses, there can be complications, infection due to chronic retention, precipitation of bladder stones due to stagnation, hematuria due to prostatic bleeding, formation of diverticuli, and of course chronic retention with back pressure causing hydronephrosis, renal impairment are some of the common complications. And in these instances, medical therapy is not appropriate. So just remember, when BPH gets complicated, they have to be treated surgically. If not, they end up having a catheter. Whereas BPH, when it's just due to LUTS and none other, and you've excluded prostate cancer, can be successfully treated with medical therapy in majority of patients. So that kind of brings us to treatment. And as I said, if it's BPH and you are confident it's not prostate cancer, and there are no complications as seen on ultrasound, renal function, and urine analysis, the most sensible thing is to start with medical therapy. And that's, once again, a very important role of the family physician. I don't think anybody expects all the patients with BPH to be referred for a urology consult. It's not necessary. It's not necessary. That is definitely the family physician's job, and family physicians can initiate treatment by starting numerous alpha blockers. There is tamsulosin, there is afluzocin, and there's so many others, right? I'm not going to mention any trade names because you know there are numerous trade names, and it is sensible to start. Educate the patient about side effects, postural hypertension, retrograde ejaculation, especially in the young, and you find that they improve within a very short period of time. Now, if it's a large prostate, then 5-alpha reductase inhibitors are useful, and this includes finasteride as well as dutasteride. There are different trade names, and since of recent, you have combination versions of tamsulosin and dutasteride in one capsule, so that's also good. But if you suspect prostate cancer, please don't give finasteride or dutasteride because it will bring the prostate, the PSA down artificially, which makes your cancer assessment very difficult. Poor response to treatment, complications or side effects such as postural hypertension, erectile dysfunction, loss of libido with dutasteride or finasteride, consider surgery. So you know, straightforward BPH, no complications, medical therapy, complications in medical therapy, poor response, or complications of BPH itself require surgery. So I hope I'm not going too fast and that I'm making at least a reasonable or delivering at least a reasonable message. Okay to move on? Yeah, so a few words about alpha blockers. There are numerous alpha blockers. They respond within a day or two. It improves the flow. It is done so by blocking the alpha receptors, alpha-1A receptors in the prostatic stroma. So these smooth muscles will relax, and as a result, the prostate will relax, and then there'll be better urine flow. The problem is retrograde ejaculation and postural hypotension. So if a patient is on multiple antihypertensive drugs, be careful, they can develop low blood pressure and you need to counsel them accordingly to avoid postural hypotension, especially in the night when waking up from bed. Now, 5-alpha reductase inhibitors, there are two types. One has the type 2 inhibitor, which is finasteride, and dutasteride blocks both receptors. It takes several weeks or months to act. So don't expect dutasteride or finasteride to act within a day or two. It will take a minimum of a month, usually 6 weeks to 3 months. The good thing about this is that it will shrink the prostate, reduce the risk of further surgery, future surgery, and also halve the PSA. So remember, if the patient is on these drugs, you need to interpret the PSA in that manner by doubling it to actually look at the potential PSA value. Now, when these initial measures fail and the patients do not have symptoms that are being alleviated, you need to then consider surgery. I am just about at the time level, so I'm going to quickly go through the surgical options. And you have the TURP, open prostatectomy is hardly ever performed now, and there are various different types. I'm going to skip TURP because you've seen this. It's in most instances quite a bloodless procedure because of added expertise. Now the present day urologists are very well trained, and this is actually vaporization using the button electrode TURIS, and the patients are home within 24 hours. This is mostly the case. There are exceptions, but often you find that it's a blood-led procedure. Can you get on to the next slide? Now, this is holmium laser, less frequently available in Sri Lanka, but that kind of enucleates the entire prostate. Click on the black slide, please. I've got a reason to put these slides across, and there you just use the laser to kind of shell out the prostate, and then it's put into the bladder, and then the chips are mosulated and taken out. But the new kid on the block is the stapling technique. This is just about to arrive in Sri Lanka, and click please. What you do here is to put a scope in, and the prostatic lobes are stapled together. So I plead with the chair to allow me to just show this slide, although I'm just a minute over time. This is likely to arrive in Sri Lanka very soon. We haven't got the license yet. So you put a little staple. It's good for small prostates without median lobe, and this is a day case done under sedation. And it preserves sexual function, it preserves ejaculation. So the young BPH patients who need this intervention will benefit from this vastly. Of course, the reoperations rates may be higher, but in younger guys, they don't want to be in hospital for too long, and they want to preserve their sexual functions. This is ideal. And the immediate improvement in flow is quite good. So hopefully we'll have this in Sri Lanka very soon. And for the infirm or the frail patients, again, we are going to have this hopefully in Sri Lanka very fast. We have now got these self-expanding stents-like things which you put into the prostate, and we keep it for a few weeks, and what it does is, due to the pressure that this coil induces on the prostate undergoes pressure necrosis and therefore opens up. So this is good for frail patients who are not fit for surgery. So the message here is that, unlike 20 years ago when I was a young trainee, we had just URP open prostatectomy. Whether it was one of our young colleagues or an elderly gentleman who needed a prostatectomy just to pee, we had only one operation. Side effects were the same, complications were the same, hematuria was significant, ejaculatory problems were invariable. One operation, have it or not. If you're not having it, have a catheter. But today, like many fields of medicine, BPH has now evolved, and bladder outflow obstruction therapy has evolved into a whole variety of options. And these options with medical therapy includes a variety of drugs which can be tailored to the patient, and surgical therapy too can be tailored according to the patient's wishes. And we are very fortunate that these options are available in most instances, and the choice of technique can be one of many. So you may encounter different types of patients in different socioeconomic environments, and BPH and outflow obstruction therapy today can be tailored according to the patient. Thank you very much, ladies and gentlemen. I thank the organizers for their kind invitation to be here. Thank you.
Thank you very much, Srinath, for that wonderful presentation. It's open for questions, one or two.
Since there are no questions, we will be continuing with the program. And first, I would like to thank our resource personnel, Professor Srinath Chandrasekara, for this wonderful presentation on bladder outflow obstruction, and request the chairpersons, Dr. Malkanti Gahlena, our president of the college, and secretary of the college, Dr. Priyantha Halabarachi, to give away the token of appreciation and the certificate to Professor Srinath Chandrasekara, and also request them to pose for the photograph.